I'm pleased to tell you that we have a great topic tonight, two wonderful speakers, and I'm going to tell you just a little bit about them, just to give you a little bit of background before we get started. And our format is going to be them presenting us some information, and then we're going to ask them all kinds of questions. Feel free to interact and participate as much as you'd like. It's really what makes it a special women's series. That's what we do. So this is Dr. Ra, Jin Ra. She's the Associate Professor and Associate Chair of Quality for the Surgical Critical Care Department here at UF. She is fluent in both English and Korean, which I think is cool. Anybody who can speak more than one language is very good in my book. I can't. She was trained at the University of Louisville School of Medicine and came from Philadelphia, the University of Pennsylvania Health System, where I worked in the 80s.
Wonderful.
She did her surgical residency and surgical critical care fellowship there. Dr. Cheshire is here also from the trauma department. He's with the acute care surgery department also. He specializes in psychology. His doctorate from the Illinois State University in Normal, Illinois, which I thought was kind of ironic for a psychiatry department. His special interests are communication, grief counseling, violence prevention, hospital community collaboration, antidepressant medication, and acute care facilities. All of that is important for me to understand. So I want you to help me welcome our speakers, and we're going to get started. Thank you for coming.
Thank you.
All you need to do is those little arrows.
Yes, thank you. Well, thank you very much for having us. We know this is a very important topic. Dave and I want to make this as interactive as possible, so please raise your hand, interrupt us. We don't want to lecture to anyone. It's kind of odd that it's echoing. So background, the ICU, as you know, is for critically ill patients, and it's full of doctors and nurses, students, pharmacists, rehab therapists. So you're inundated with a lot of people coming in and out of the rooms. Approximately 25% of the deaths occur in the ICU, and that's in the US alone. And as our population ages, as we get heavier and less active, we kind of accumulate medical problems that make it harder for us to recover from illnesses. Also, we have access to care issues, as everybody knows, and with lack of health insurance for patients to get the care that they need. And so the ICUs have needed to grow, but the amount of care to provide and the providers to provide that care, there is a shortage. And as a designated caregiver, you should expect daily rounds either by phone or by face-to-face communication, and always be free to ask for a second opinion or advice about what's going on by other providers, and that should be given to you fairly freely.
How many of you have had it?
It's pretty loud.
How many of you have had the opportunity to have a family member in an intensive care unit? All right. And you saw about 500 different doctors from different services while you were there, give or take. And just curious, how many of you felt that different doctors either were telling you different things, or you felt that they weren't communicating with each other? How often is that happening? Yeah, that's good for people like me, because without that, they don't need a psychologist to repair the damage. The rest of the doctors. No, there's actually a reason why that happens. And I'm interrupting.
No, please.
But the reason that happens is because we work over at UF in downtown campus. And I'm not an MD, I'm a PhD. So when I say this, it's not quite as self-serving. All of the MDs and DOs that I work with are exceptional at their job. And I promise you this. If I'm the person in that hospital bed, or if one of my family members is the person in the hospital bed, that's the hospital I want to be at. These are the people who go around the world and teach other people how to do what we do. We are exceptional at saving lives. But when you're in an ICU setting, chances are you've got a cardiologist and a pulmonologist and a nephrologist and a trauma surgeon, and you've got all these different doctors coming to see you, or the person that you're there visiting. And it's possible that one of them is talking to you and saying they're doing way better than they were doing yesterday, and they're talking about from a kidney support standpoint. Then the next doctor comes in from a pulmonology standpoint and said, yeah, they still aren't where we want to see them. We're still day to day. We're not out of the woods yet. And you feel like you got good news and bad news. And so it's not uncommon to feel like you're being pulled in two different directions, and you wonder, do these doctors just not talk to each other? Well, they do, and we do that through the medical chart, but a lot of times it's confusing for people who don't do this every day, and mercifully, most people don't have to do this every day. And so if you start to get confused about what's really happening, if you happen to be in an acute care facility and you're working with trauma doctor is always the one who's going to know the patient from the hair follicles down to the toenails and everything in between. In acute care, the trauma doctor is really kind of the conductor for the entire orchestra of people you've got. And it really makes sense to have one point of contact so you can say, look, I'm getting a lot of information. I really need somebody to talk to about this. At UF, we have psychologists that are available to you. And that's basically, I see my role a lot as an ombudsperson to kind of filter through some of that, or a case manager, or a chaplain, or a social worker. Somebody who can kind of get rid of all of that medical speak and filter it down to your level and explain why you're hearing different things from different doctors. That's probably the biggest complaint I hear is either no doctors are talking to me, and I know you're getting doctors all the time talking to you, it's just so hard to filter all that when you get it, or I just don't understand what they're saying. They're saying different things and it's not helpful. So always, 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 if you're feeling confused about why you're getting conflicting information, ask to talk to one of those other people, or always the room nurse is great for you too. They're usually pretty good about being able to filter it all out.
And I want to highlight what Dave said. The intensivist or the ICU doctor should be the one taking all that information from the other specialists and forming a singular plan. Different organ systems may compete with one another, so priorities may change. During the day, sometimes the patients change too. They're not the same as they were in the morning than in the evening. So if there's any confusion, ask for the ICU doctor, whether it's a surgical ICU, medical ICU, or neuro ICU. Say, I want to talk to them so they can assimilate all that information and give you one solid plan. And thanks for highlighting that because that's very true. We have so many different doctors, medical care professionals that are in and out of that room, and they may have a piece of that information, but not the whole picture. All right. Any questions so far? Okay. So, surrogate decision making. Who's a surrogate decision maker? Quite a few of us. Okay. Do you want to go through this one?
The worst time for you to designate who your next of kin or surrogate's going to be is when you aren't able to make that decision who your next of kin is going to be. And we have a legal chain that we follow because most of us don't designate anybody. We don't think we're ever going to get hurt. No car crashes occur in this community. Nobody jumps off bridges or gets struck by lightning or things like that. But it's so important for you to have a conversation with your parents or with your loved ones or with your children so that they know kind of what your wishes are and you know what their wishes are should, God forbid, something happen. Because so often people come to us and say, we haven't had this conversation. I don't know what they want us to do. But you're still in that role. We still look to you because no matter how remote you may be from your different family members, you're closer than we are. And you're going to know your family way better than we do. And so we're looking for you to be the voice of the person that you're making decisions for. Not necessarily what you want, not necessarily what the hospital wants, but what you think your best guess is that they want. And down here at the bottom of this slide, we have the Florida legal next of kin chain. Now this chain changes from state to state, but it's generally pretty consistent. But whatever state, if you're from Georgia, for instance, it may be slightly different. I don't know what theirs is. But the very first person that we talk to is the spouse. And then we kind of move on down from there. And if we can't find anybody, we'll actually go to another hospital and have a social worker assigned to be your next of kin. And just before that is a best friend affidavit. Now I want you to think about how this works, because if you don't name a next of kin in a living will, and we're going to talk about living wills and things later, but I was just telling this story. We had a patient come to the hospital. He was in a car crash after being at dinner with his date.
She was not hurt. He was critically injured and had a traumatic brain injury. Wasn't doing so hot. And so they get there, and so she became the next of kin because she's who we had, and we couldn't locate parents or children or aunts or uncles or anybody else, so we had her. This was their first date, date number 1. And she had to fall into the role of next of kin, at least for the day. She finally took me aside and said, I don't want to do this. My response was, run and don't come back, and we'll get a social worker for you. But that's how we do it, because we're looking for people who know you best. And without your guidance before something happens, we do the best we can. Now, I'm not sure that all of you, think about the last first date you had. Well, or the one just before that last one, presumably you're still with that person. Maybe that's not the person you would have wanted. So it's important for you to kind of consider this now, so that when the time comes that you may need somebody like this, that's who we're going to look to. And again, somebody to speak on your behalf, not what they want. And if you're doing this for your family, not what you want, but what perhaps your parent wants, or your spouse wants, or your child wants. Dr. Rod and I, just before we started talking here, we're talking about a gentleman in the ICU came to us with a spinal cord injury. And the family was absolutely convinced he wouldn't want to live with a high spinal cord injury where he can't move his arms and legs. Fortunately for us, this gentleman was able to wake up and let us know his wishes. That generally doesn't happen. So make sure that you all know what the wishes are of the people that are important to you in your life.
And one point that I want to highlight is when you're making a decision for someone, just remember it's their beliefs and their wishes. Sometimes the decision maker and the patient have different beliefs, different ways that they would like things to happen. So remember to do it for the patient and individual. And because sometimes it can be really difficult when it's a very emotional situation.
One last point about that next of kin chain. It's different for pediatrics. So if you got someone under the age of 18, Florida has a different chain for emergency care. When it's parent or court guardian, and then it just stops there. And so then we need court orders to do things. So just bear that in mind should, again, God forbid, you be looking over somebody who's under the age of 18. All right, guardian. Anybody in here aware of the guardianship process, served as a guardian? Okay.
Couple hands.
What?
Couple hands.
Okay, a couple of hands. Guardianship is going to be a little bit different than just power of attorney, which I think we talked, oh, it's right there. And we kind of confuse these two things a lot. Power of attorney is generally when you are capacitated, you have the capacity to make decisions, but you want somebody else to be able to speak on your behalf. So you may get a legal power of attorney, so someone can write checks for you or sign forms for you or something when you go on vacation. That's power of attorney. A portion of power of attorney is healthcare decision making. And so if you're going to go in for a procedure where you're going to lose consciousness for a while, and you're going to anticipate if complications set in or if I have a lengthy recovery time, I would like Bob to be able to sign forms for me or decide what my care looks like. You'll sign a health addendum to a power of attorney. And we do that fairly frequently. Guardianship is different. And when we were preparing this discussion, we wanted to talk specifically about guardianship because as people advance in age, guardianship becomes more and more prominent. One of the things I do in my night job, not my day job, is I evaluate people for guardianship hearings. And basically what happens is somebody my age is concerned that mom or dad, they're not clicking on all cylinders the way they used to be. And they're starting to give a lot of money to televangelists that they see on UHF on television in Chicago. And yeah, that's my inheritance, and I'd rather it not go to somebody I don't really trust. And so I petitioned the courts to be named my dad's guardian. And the way that works, if you're concerned about somebody in your life, your parents, a sibling, somebody that you're fond of, your spouse, and they lack the ability, or it's your opinion that they lack the ability to make the best decisions for themselves across a broad spectrum of things, from financial decisions to contracting, to going to school, to getting health care, to where they're living, you can petition the courts to have an involuntary guardianship. Now, if the person has that capacity, then they can enter into it voluntarily. But what guardianship is two different options, limited and plenary. A plenary guardian, which is the most common, means you're asking the courts to take away all of their rights. And certain of those rights will pass on to you as their guardian, if you are so named. Where this person's going to live, when this person is going to get health care, what they're going to do with their finances. Those things will pass on to the guardian. Other things disappear entirely, like the right to vote. You cannot vote for an incapacitated patient. They just lose that right. And that's, sometimes we'll hear delible and indelible rights. Delible rights can get passed on to a guardian. Indelible rights disappear. They don't go to somebody else. And so that's a plenary guardian, looks at all of those things and says, this person is no longer able to do these things. A limited guardian means you're asking a judge to go point by point by point and decide, can they do this, can they do this, can they do this? And that happens a lot with people who have large sums of money that they're having a hard time doing a ledger for anymore. They still know who they want to vote for. They still have a good reason for voting. They still know what they want to do on a Friday night and go out and play bingo, things like that. But they can't do some of those things that require a little bit more cognitive thinking. And that's a limited guardian. To do that, you need to go through the courthouse, and basically an attorney will be assigned to you as the petitioner and to the person that you're asking to take away rights. They'll get a separate attorney. And it can be a lengthy and expensive process. Again, the best time to decide this is before it gets to a point where the courts need to get involved, because now you're talking about considerable legal costs, and also families get torn apart when these kind of things happen.
Any questions or comments about guardianship or surrogate decision-making?
Is there any way to get around that cost?
The question is there any way to get around the cost? And the short answer, well, there's two ways. One is go to the cheapest attorney you can find. And two, if somebody lacks means, they can be declared indigent, and that means the state will pick up the cost. And that basically means they don't have any cash flow in order to handle these kind of things. And that happens maybe 50% of the time that the people I go and see are declared indigent. But that actually, too, is a legal decision. So you'd have to have the attorney petition the courts to say this person can't handle, or doesn't have the finances to pursue this. Yes, ma'am.
What do you do with a bullheaded spouse that decides he's going to run all the finances, and then the bills don't get paid because he forgot? And you tell him and you ask him to put it on a calendar, let me help look at,
I can do it myself.
how do you respond?
I have the perfect person to answer that. My wife is right there.
You get it trained early. I'm in charge of the finances.
It doesn't work that way.
No, I am the sole bearer of a Y chromosome in this room. And I know better than to even begin to answer that question in any sort of way that defends the bullheaded spouse that does that. So, ladies, let me turn that around to you. The question is, you've got a bullheaded spouse that insists on being in charge of the finances and then doesn't necessarily pay the bills on time. I'm sure that this is something that happens fairly frequently because I'm absent-minded, and it's not going to get any better as I get older. How does one handle that? That's not a bad option. Setting things up for auto pay when you can. I'm sorry? Power of attorney, or I mean, once you start doing those things, you basically have to break through that bullheadedness.
You're stirring up the hornet's nest.
That's all the utility companies who are making the bills been paid before the due date. Call the utility company to see if your bill got paid before the due date. You know, if you at least have a list of what the due dates are, you
I
can
know,
call.
just put it on the calendar, honey, let me know when it's due and I'll remind you.
As,
Go do that.
as a clinician,
Now you go do it now.
As a clinician, the thing that I would be concerned about is, are they forgetting other things too? So there could be a medical situation, and then maybe the primary care physician evaluate to make sure it's not a medical reason why that things are being forgotten. And sometimes behavioral changes can be a sign of changes in their mental state.
So have the GP wag his finger
it helps sometimes when it's someone else besides you, right?
Good.
Just a quick question. I have a spouse that is changing mentally, like mental, almost like was signs of something like dementia, early dementia, but still in their work environment of working, able to have a function of the job, but you see a lot of forgiveness and all this, but not so much in this case. But then it's getting to a point to where, it was referred by a doctor to go under psychosis evaluation. So I'm not sure, whether powertrain or it was some other, I guess, other laws that I'm not aware of, where his medical is now being affected, that what I could prepare to do as a spouse, as a clinical part. You see what I'm saying?
Yeah. The question, or the issue that just came up is, what about you have a spouse that is starting to be more forgetful? Still living their life or trying to live their life the way they always have, but you're noticing that they're becoming more forgetful, not getting things done, you're getting concerned about them. How do you move with that? And something I want to be clear about is two things. One, I am not an attorney. And so the first thing, if you're talking from a legal aspect, neither Dr. Ra or I are going to be able to give you legal advice.
Well, it's not legal advice, it's more like, we're talking about powertrain and
Sure.
guardianships or something like that. It's not so much as I'm looking for legal advice, but we're talking about the different process
Right.
of when things turn for
Sure.
their worse.
I just wanted to be kind of clear on that for everybody so that you're not looking to what we see as gospel. And then two, I'm not a gerontologist, though I work with a lot of people in advanced years. I'm talking to you as a psychologist that works in trauma. And so all of it, I'm 46 years old. I'll be 47 in a couple of months. For the last 6 months, I've been having a hard time raising my arm up to shoulder height. My arm is killing me, and I have not gone to a doctor yet. Anybody know why I haven't gone to a doctor? Right? Well, no, right here. And why, the answer right here is, I don't want to know the answer. How come?
Because it affects your in charge on the man, I take care of my family, you're afraid
Fear.
you'll interfere with that.
Because for one reason, for me, I just don't have to, actually what it is, I don't want to have to shell out the money for an MRI. But no, but fear guides us. We are masters. Every single person in this room, male or female, so male or female, when something happens medically to us, we try to downplay the importance of what that is, right? We do that because it's scary. The alternative is scary. And so what we do is we either ignore it, denial, or we make excuses for it, or we work ways around it. We compensate for it. And more often than not, the other people in our life do that with us too. And we enable people that we care about because we think we're doing them favors. Long term, we may not be. But we do that because we honestly care and we want them to be able to kind of live their life the way they want to live their life and the way they always have. And as you get older, this becomes more and more pronounced. If I'm 70 years old or 80 years old, and I'm starting to have trouble remembering things, and I think if I go to the doctor and say I can't remember, he's going to send me to a nursing home. And I don't want that.
He's gonna take away your driver's license.
He's going to take away my driver's license. I don't want that. My dad's been driving up in Chicago. He just had a cataract removed. I'm like, how long have you been driving with cataracts? It just scares the heck out of me. It's, I see so much better now. I'm like, I'm not worried about you now. But that's what we do. That is what we do. And so we have to break through the fear of that. And the very first thing I would recommend is having a frank discussion with him if you have not already. A frank discussion, in this case, spouse, with anybody you're worried about, and let them know, hey, I've noticed this, hon. What can I do to help? Because this is worrying me. And if you're not going to go to the doctor for yourself, can you at least do it for me? Which is what she does to me. And that can be powerful and strong. Once you get into these options, we're starting to get into the legal aspects, and this will fix the problem, but it's going to have consequences. This kind of thing does tear people apart more often than not because it's forcing the exact thing that people are afraid of. So I would recommend the conversation first, and I would recommend talking with the doctor first and seeing if you can come up with a plan that way. It's an excellent question. The title of this one is Difficult Decisions. Unfortunately, these are not going to be easy answers. For any of your questions, there's no easy answer. I know it's hard, and I'm sorry.
So, one of the options is just discuss it with your spouse. The second one, if they're not listening, and maybe call the provider PCP and say what your concerns are, and during the next physical exam, they could do a cognitive evaluation, and then maybe they can have a frank discussion looking at the test itself to figure out what's going on, and maybe they may listen to the physician who's looking at them and evaluating them. And those are little options that may help.
And you had a hand up.
Does Florida have a springing power of attorney? I know that they had it in Texas. You could have it signed ahead of time, and it really only went into effect at the point somebody was mentally incapacitated. You could get that power of attorney, but it wasn't in effect, like somebody had dementia or whatever, and they were fine for a while. They could sign it of their own free will, knowing that at some point they were not going to be able to take care of and you could eliminate all the legal fees in the middle.
I suspect they do, because a lot of times when people sign power of attorney with us, it's on the assumption that should I become incapacitated, these people. And so those things, and that's a very narrow portion of it. You'd have to talk to an attorney, but I suspect that they do.
So no Texas.
Interesting. So do not resuscitate, living will, and advance directives. Is it cloudy or easy to discern them? So living will is the same thing as an advance directive. Basically, it's a legal document that allows you to decide what you want done when you're unable to make your own decisions, all right? So we use that term interchangeably, but it's the same. It is not the same as a last will and testament, which is more of an estate planning financial document that people may have. Any questions about that? Okay. So what is the DNR? A DNR is an order for the provider not to resuscitate you, which is putting a breathing tube in or doing chest compressions or a defibrillation if your heart were to stop. And allows the patient to die naturally. It is reversible. So just say that you initially said DNR for me, and then you decide during your hospital stay, no, I do not want to die naturally. I want all the resources to bring my heart back or put me on a ventilator to live longer. And you can do that. Different levels of DNR do exist, and I won't go through all the details, but you can exclude some treatment, add treatments. I do avoid that because it can be very confusing for the provider, but each facility has different levels, and please ask questions about what those different levels are. But there is the DNR, DNI, which is do not resuscitate and do not intubate. And then there's the different levels, and again, they are reversible. It's not permanent. So when a provider wants to discuss a DNR status with you, it is not a permanent status, but it is status most people don't reverse usually, but it can be done. So hopefully that will open up discussions between you and the provider.
Does everyone know when Dr. Ross says do not intubate, what intubation is? Are you familiar with that term? That's the breathing tube down your throat. So it basically is to protect your airway. Okay.
A question about hospitals, right? We live in a city where there's a lot of hospitals. Some of them are religious affiliation hospitals, some of them are not. When somebody comes into an emergency situation, can they assume that these are baseline understandings no matter where they go? Or does an institution and culture affect assumptions about what the DNR means?
Most facilities have a similar language. The different levels may differ. When I trained at Penn, it was DNR A, B, and C. We don't have that here at UF Health. But some places, for example, you may have a state of Florida DNR that would travels with you. So if you're in a nursing home and you have a state of Florida DNR, it doesn't matter which hospital you go, that paper will go with you and your wishes should be followed. Now, if we don't have that, you'll have to establish that at each facility that you go to, unless you have a living will or advance directive that specifically says that not. But most people don't carry that around with them, and sometimes in an emergent situation, there's no way to rifle through all your belongings to find that. Good question.
So, like, if I file a living will to UF, and I forget they take me to another hospital, does that living will go with it, or?
Your living will is a legal document that should be used at any facility.
How do they know?
You would have to have someone that you trust to provide that information.
And that's an excellent question. These are all excellent questions, by the way. Two things about, first, other facilities, especially even in Florida, DNR is being changed to AND, which stands for Allow Natural Death. They're exactly the same thing, it's just the verbiage may change. And when you go to a hospital for an elective procedure, so you go in because you need bypass, it'll probably happen rapidly, but you'll have time to get the documentation out there and you'll talk with your doctor about how you want. When you get into a car crash and you wind up in the trauma center or the emergency room, that form probably won't be there. And so you'll probably get resuscitated, intubated, unless the hospital happens to know you, in which case there's a couple of legal meanderings that they'll go through. Or if somehow somebody there knows you and says they have a living will, don't do this. I will tell you, and it makes just absolute sense when you think about it, doctors and nurses and all the characters within your treatment team are human beings and would rather have you living than dying. It is hard to allow someone to die in front of you. I don't know how many of you have had the misfortune of watching somebody die. It is not an easy process, even when you know it's something they wanted and it was the best thing for them. It really sucks. I tell my partner at work, I'm good for one of those a day, and after that I'm sitting in my office all by myself. I can't do it. Other people have a higher tolerance of being able to do multiples of those a day. I can't do it. And I'm telling you, downstairs in the ER, absent that form, or even if they know there's a form out there, they may actively not look for it in order to save your life. So this is basically a way to make sure your wishes are known within the process, but it's not a complete 100% degree of certainty it's going to follow you at the time you need it right there. Through the process of your hospitalization, hopefully somewhere in there things will kick in to make sure your wishes are followed. Okay.
My doctor recommends that, it was suggested that all of his patients give him a copy. That way, if anything happens to you somewhere and you contact your care physician, they know. They'll know what to say because you're their patient. So my doctor has mine on file.
Everybody hear that? That's excellent advice. Make sure your primary care physician knows what your wishes
So
are.
like if you went down to Orlando with family and you went to Disney World and something happened and they took you to Disney World, Orlando Hospital,
Do you have a physician?
then they
call
would
my
supposedly contact your physician here in Jackson.
He knows. He has all my medical records. He knows. It's on file.
Somebody's gotta tell them who your physician is.
Yeah, but if I'm with my family or someone,
Well,
they would know.
and if you have your insurance card on you, that'll, yeah.
And I was gonna say,
The person you designate as your healthcare surrogate should have a copy of that document.
yes.
That's the next thing.
Exactly.
That helps.
Sometimes when you travel to monkey places, you don't always bring all
But
that
that
paper.
family member, if you realize.
I don't bring it from my
And I
husband.
keep my health care card with me, just like my driver's license.
Your health card,
And
yes.
my doctor's name is on it. My attending physician is on it. So just like I got my driver's license, I got my doctor's name in my.
I will tell you, we do incredible calisthenics to find out what your medical history is when you come into an emergency situation. And so we will do everything we can to find your next of kin and what your history is.
But just to emphasize, if we don't know for sure, we're going to err on saving your life. And then until we can get the actual documentation or actual next of kin to help us with that decision. I think you had a question.
The living will, it sure that the doctor's not gonna be like, oh, no, she wrote this, this is what we're doing. I mean, how's that work with the person that's trying to care for?
Do you want to answer that one, or do you want to go?
Yeah.
Is that a legal question?
Yes.
Well, yes, but we run into this a lot. Again, we work in trauma, so we get horrible situations and people have to go and navigate them. And more often than not, the families are not ready to let go of their loved ones, despite what their loved ones have said. That's human. And we do our best to work with everybody and make sure we have a satisfactory outcome. But if we have a document that says this person wants to be a do not resuscitate, and that was their decision when they were capacitated to make that decision, we will follow that. The person, the family member who says, no, do not do that, Florida actually has a law written into this. That person has a time period, I think it's 7 days, I can't remember off the top of my head, where they can go to a court and get a court order to do whatever they want done. In my, I've been at Shands 11 years, it's never come up, but they do have that legal remedy. The one and only one way around this is if you and I are married and you have a DNR somewhere and you're in a coma and I come in and said, yeah, she did have a DNR, but yes, the day before this happened, she and I were talking, she said she wanted to change that. We would trust that that person was operating on your best interest. But if absent that kind of discussion, we are doing our best to do what you wanted. And the forms are what guide us, absent any reason to believe otherwise.
And it's true, we've had families that disagree with each other with the living will, and we do our best to really meet and have a discussion so we're all on the same page, so we don't have to do what the patient wants, irregardless of what the family wants, because we don't want them to leave so unhappy about the situation. So we have multiple people, multiple discussions, and try to find a happy medium so everybody's happy, the patient gets their wishes, and the families feel there's a closure with the event.
That's two questions. The first one is, how many different levels of DNR? Because I've seen several, but this is more than several.
There's a few, but what we have here is not so much levels, but you can pick what item you want. Some places have a level where I trained, it was A, B, and C. But here you can actually pick medications, intubation only, no medications, and things like that, which makes it very confusing, which I recommend not to, but everybody has a right to choose what they want for their resuscitation.
It's like going to an auto mechanic, and if you're like me, when you go to an auto mechanic, you're listening, you don't pay any attention. You nod knowingly. Yeah, that all sounds good, do that. And when we break down medical procedures, like do you want this, and if this happens, do you want this? Unless you have an MD or DO, you're probably not really going to understand what those things, much as you don't when you go to the auto mechanic. I don't, and I work alongside these people every day. I can't, I lack the acumen to know exactly what I'm signing there. And so blanket DNR for me makes more sense than going down and kind of cookbooking. I want this, but not that, this and that. It does get confusing, and it gets confusing to follow, frankly, too.
I'll give you an example of why it's confusing. So if you're not breathing and your heart stops, but you just want chest compressions and not a breathing tube, if you don't have oxygen, you're still going to stop, right? Which is why I want to avoid the multiple pieces and differences, because if you intubate and do not do chest compressions to resuscitate the heart, then that's the same thing. But it is confusing for people who are not understanding of that. And in an emotional situation, it's very hard to kind of piece it all together, which is why I try to avoid the tailoring of the do not resuscitate for that reason. But it is there for you, and please ask the physician team to explain those levels and what it means to do one thing or not, so that you're at peace with that decision. There was another hand.
So if I came in critically and in my mind, I want you to do everything possible you can to save me, but I also don't want to lay in that bed for 3 or 4 weeks incubated and stuff like that. Is there a portion of the DNR that you can say that, or?
In your advance directive or living will.
So you can.
If it's not reversible, you can make those statements. When you're doing your advance directive, make sure it's very specific. Some of them are very short and generic, which doesn't give you much more than a DNR. And others are very detailed, like I don't want a feeding tube, I don't want a tracheostomy, I don't want IV fluids. So when you're looking for one, make sure it's specific, and you can have a time limit. After 7 days, if I'm not better, take me off the breathing machine.
You don't think that I'm gonna get, yeah, because I wouldn't
Right.
want to put my family through that.
Right, and I think that's very wise. And then also tell your family so they not just see it in a document for the first time, but know that these were your wishes from a long time ago.
And as you're deciding what those timeframes are, I would have a conversation with your doctor too, because sometimes 3 days is simply not enough to make that decision. Sometimes 7 days makes, 7 days usually
Pretty
is a
good.
good one, but
Well, I was thinking along the lines of, a brain trauma or something that the chances of you recovering from are.
well, again, you can
but
put
the
recovery in
doctor's in a serious
quotations
way, so
because,
you don't know.
Yeah.
yeah, and it's not an all or nothing. It's and we can't give you a percent. Patients would always ask us, what's going to look like? Are they going to wake up? And are they going to be able? Somebody once asked me, are they going to be able to play golf again? So let's concentrate on feeding themselves first. But it's hard. Those are well, actually, it's not hard. It's impossible. Sometimes we can give you, without a shadow of a doubt, this is as good as it gets. But those are relatively few and far between.
Yes.
So are you guys, when you get the living will or the DNR, do they educate the family members? And the reason why I'm asking is because if you're at home, all these examples are like in the hospital. But if something happens at home and you stop breathing, the natural reaction is to call 911, have them send out paramedics. But if your family know that you are DNR and you stop breathing, I wouldn't want the family member to just stand there and let you die because they are unaware what a DNR is, because they believe when the paramedics get there, they're going to revive you. And in their mind, they're like, well, Dad told us not to revive him, just, let him go.
I guess if we can walk away from one thing from this question, always call 911.
Okay.
Just do that. And if you know what their wishes are, express that when the EMTs get there.
I have something to add to
Sure,
that.
sure.
And the reason I do is because my mom is dying of cancer. She's under hospice care. We have a DNR for her. It's posted so that if we call 911 and she's not breathing and they come in and see that DNR, you're not going to do it. And we have to have it posted at the house. We've got it posted several different places. When it first comes in the front door, in her bedroom.
Just in case somebody that's not familiar with her calls.
Exactly.
Can you take a picture of it and show them, say, this is the picture of what was signed at the hospital?
No, I mean, you can, I guess.
Would a
But
picture be valid to show someone?
that I don't know. I mean, we have several copies of hers.
Yeah, it's probably best to have a copy.
If we take her somewhere, I have a copy in with her ID, with all of her medical, any of her medical papers, so if something happens, there's her
Sure.
DNR.
I suspect a hospital would accept a photograph if you have it on your phone. We'd probably want a hard copy of it because we accept faxes. And so, I would rather have something in hand than that, but
But if you're traveling out, running the world, you don't always carry papers.
yeah. Well, I don't know what other countries will do with this either. So I can only talk to you about what we do in Florida.
Well,
But
I'm saying running the world, in
Yeah.
Arkansas and California.
different country to me.
But
I
always
don't-
have an emergency contact so they can answer those questions so that nobody has to, go through bags and things like that to look for a document that may not be there or not near them. So make sure that you have your emergency contact updated with the right number. So if they have to call somebody, you can provide that information. There was one other question.
So on the DNR, is there like an expiration on it since it is reversible?
No expiration unless you change your mind.
So what if you're like not able, say like you have one and then, like you recover, say you got cancer and it's not looking good, but, act of God is taking over and now you're healed. And then you get in a
Well, that's hard because if nobody can speak on your behalf about your changes, then the paper may be what they have. But usually what happens in that case, no one's going to know you have that paper. So people are going to err on trying to resuscitate you and bring you to the hospital and then find out who your next of kin is to give you the information and updates, and then maybe find out from them. It's not, our EMS team, as you know, go out to the field, and it's not one thing that they're looking for is a DNR. They're going to try to save your life first, and then decide on who's the next of kin and who needs to know where you are.
But what if the DNR is filed at that hospital that you're brought into?
Once, well, kind of the way that once that procedure goes its course, so you had cancer, you go into remission, you no longer wish to remain a DNR, you need to let the team know that you would like to rescind the DNR. And for the most part, we kind of assume that happens anyway, but you need to have these conversations with your loved ones and with your doctor.
Updated.
Yeah.
Would that be the same thing with the advance directives also?
Yes.
Say if I had surgery last year, advance directive was done, I'll leave here tonight, get in a car wreck, and I go back to Shands where the advance directive is.
Well, if
I know you're still getting.
See, in an acute kind of thing, advanced directive, I need a surgery tomorrow. I'm going to get general anesthesia. Should my heart stop while you're working on me, let me die. That's your advanced directive. And then after the procedure, that advanced directive is for that procedure. And so, again, we're kind of talking about different things here. A DNR is different than an advanced directive, is different than a living will. And so what you want to do is you want to make sure that the people who are caring for you know these things.
Yes.
And again, communication is your friend here. And kind of putting this outside of you, you need to know this about the people you're going to be taking care of. So your parents, your children, your brothers and sisters. And these are conversations that are never fun to have, but are important to have. And in some like we talk about these things too. And what I tell Lana is, I don't know exactly what I'm going to want, but just follow the doctor's advice. And if the doctors say I'm not going to make a meaningful recovery, pull the plug. There'll be a line to get to it. I have plenty of enemies that are going to be yanking that thing out of the wall. But you really need to have that communication. It is so important.
One of the things I was going to say is when we thought about why this topic would be really helpful, it was because we wanted to give people information to think about it before they were relying on it, right? So the importance of having information about what these tools are is that when you're not in an emergent situation, you can plan, you can have difficult conversations, you can talk about things. I think most families struggle with this. They struggle with it usually just in a general care situation, not when somebody shows up at the emergency room. So the point of today's topic was to help you understand that this is a preparation. It's not a one-time thing and done, that it's a continuing conversation based on your age, your personal situation, family, and what's happening to your loved ones. So doing it once and then being worried about whether it'll activate when it shouldn't is really not what we should be thinking. We should be thinking, okay, I need to think about this and let everybody who I cares about me and is going to be there for me know. And I might need to change my mind more than once about this, or my parents need to change their mind more than once about this. Because most of us aren't making acute care decisions when this comes up. It's a change of life. Okay, so now my parents can't do the things for themselves anymore, and I feel more responsibility. So I want to know what my options are so that I make the right decision for them. And that's ongoing. That's not an acute.
Correct. You will change your mind over time when things change and happen to you. Just make sure you communicate that with your loved ones and change the documentation too.
I think some of the struggle with family comes between the different forms. So is it just one form that you can put everything on? The forms are individually tailored based on your situation. And some people think they should have all three, or some feel like it's one living will tells the whole story.
So the advanced directive or living will can have the DNR and all those specifics on one document. So the DNR is part of an advanced directive. It is not a standalone document that tells everybody exactly what kind of care you want in case you're not able to make decisions, or you're not able to, or you're so critically ill that you're not going to recover. if that makes sense. And pretty much when the question is who should have one, pretty much any adult should have one. There's not one specific type of person should have one, especially if you have responsibilities, you have a spouse and children or someone else you're caring for. And again, just to express the communication about what you want and have the one you are the surrogate decision maker for, have them express to you what they would want. So how do you start one? You can start with an estate attorney. They're expensive, but they will do everything from your estate planning as well as your medical advance directives and DNR. There are some online websites. I'm not going to plug one, but the ones you saw on television, like LegalZoom, will have one. It also has a fee attached. All these documents require notarization. And if you go to a hospital, they can provide free services through case management or palliative care, and they can also be notarized at that time as well.
It's right here, right there. Basically, UF offers this at all the doctor's offices, and you have them here. They're relatively easy to fill out. It's a great place to start, and it gets you thinking along these lines. And it'll cover you here. For those of you who haven't picked one up, I encourage you to do so.
Oh, it's got a happy little card in there.
And it's got a happy card, too.
Yeah, yeah. So you take it with you, and strap it.
Right. Any questions about how to obtain an advance directive or living will? Yes.
I have one. So many older people are getting Alzheimer's. And like we have a friend, his wife has had it for 15 years. And he took care of her phone for quite a few years, and then he got where he couldn't handle it. So now she's in a nursing home, been in a nursing home for over 10 years.
Oh, wow.
And she doesn't know any family. Is there a form you can sign or something that if you ever get in that state?
That will be your advance directive.
What?
Your advance directive.
You can't?
Yes.
Yeah, essentially, to make sure everyone heard, is as you get older, you run the risk of developing dementia. There are lots of different ways you can get dementia. In this case, we're talking about Alzheimer's disease. And it's a progressive disease. It can start off slowly and take years and if not decades to get really, really bad. And the question is there something you can do that the advance directive would kick in should you get to a point that you're no longer recognizing family members or you forget how to swallow or those kind of really, really bad symptoms? And the answer was the advance directive can be written that way. Now again, advance directive here would be no escalation of care, no intubation, do not resuscitate, those kind of things. If you wanted the doctor to perform something to help you pass peacefully, you got to go up to the Pacific Northwest. We don't do that here. So there's no euthanasia in Florida, but we will not escalate care for a patient that doesn't want it. Does that make sense?
So the advance directive will help guide your care when you can't speak for yourself anymore. So if you have that in place, then your loved ones can follow that without feeling like they're making that decision when you're not aware. So it's always important to have one because we don't know if we're going to have dementia or medical illnesses that will not allow us to make our own decisions.
Which is a great segue.
So is palliative care and hospice the same? And the answer is no, but oftentimes people confuse the two. Palliative care provides compassionate care like hospice while the patient is receiving treatment. Hospice care is relieving symptoms when the patient has less than 6 months to live and is no longer curable or in treatment.
A lot of times people in the hospital, when we talk about doing a palliative care consult, thinks that means that we're giving up on them. And I was presenting once to the American College of Surgeons, and I was talking about palliative care, and one of the surgeons piped up and said, I like to think we're all palliative specialists. And that's true, because palliative just means comfort. And rarely do you go to a surgeon who's not going to give you anesthesia while you're recovering. or having the procedure. And so that's the palliation side. Really, palliative is this long continuum of aggressive medical care, but we're taking care of pain, to weaning back the aggression that we have for medical care and concentrating more on comfort measures and quality of life rather than quantity. And then all the way on the other side of palliative, you get into hospice, which is no longer curative and is more about comfort and getting the most out of the days you do have left. And so palliation is really the entire dimension of medicine. Palliative specialists really kind of focus more in the middle, tend to focus more in the middle ground, and then hospice usually falls on the far end.
It's for comfort control. It also helps the families start talking about goals of care, especially when it hasn't been discussed before. And they're great at doing it. That's all they do. And so especially in those families that it is a very difficult topic, they do a great job trying to rally the family for the patient and not to think about too much of the differences in what they each want, but what the patient would want. And they're really good about doing that. So whenever you have someone in the hospital and you feel like that the patient is not getting better, your loved one's not getting better, you can always ask for a palliative care consult. And then if your healthcare team recommends that, I would definitely say that would help you and the patient. Yes.
We've been going through that with my mom, and a lot of times people think when they call in hospice, they're giving up, and that's the end. My mom has been in hospice care for over a year.
Wow.
She has untreatable breast cancer and end-stage dementia.
Mm-hmm.
But hospice has been wonderful. And most people think that you can only be in hospice for up to a certain length of time, which was kind of a concern for us.
Sure.
Because last year, the doctor gave her 3 to 4 months. It's been a year and a half now, and she's still here. And when I talked to the hospice nurse about it, she said, we're not going to just kick her out of hospice care because she's been in here for a year.
Correct.
You know, she said she is never going to get better. And we know that, you know, we're not under the illusion that she's going to get better or she's going to improve or whatever. But they're not going to just kick somebody out because they've been in there for a certain amount of time.
Correct.
If the end result, or if they're not going to get better, then they're going to stay in there.
Correct.
And just because you call them in doesn't mean it's the end. And a lot of people wait till the last minute to call hospice in.
Mm-hmm.
We had no clue. We were just flying blind, didn't know what to do. So we asked her doctor, when should we call in hospice?
Mm-hmm.
He said, my recommendation would be now, and they have been wonderful.
And most patients and their family experiences have been that way. So when the healthcare team recommends that, it's not like we're giving up. We just want to make sure that we meet the emotional and psychological needs of the patient and families as they're going through a tough time in their health care. All right, any other questions about that?
So when palliative is mentioned, hospice is not automatically let in?
No. And that's what most people think about. And when we bring it up, families already build a wall saying we're not interested in that. And it's not the same. It is part of it, but not the same. Palliative is provide treatment and assistance during treatment. And hospice is when treatment is no longer curative and provides support and comfort for the end of life care. Yes.
I know I have a brother that has COPD, and I was told a hospice, I thought, but don't you have to have black cancer, maybe a certain time to live?
No, it's any medical condition that's going to limit your life. And it could be heart failure, it could be COPD, it could be cancer too, but it's not always, I think, environmentally, or not environmentally, but what's the term I'm thinking about? I think in everyone thinks of it as associated with cancer, but it's not always cancer. You could have other end-stage conditions that require, like dementia, for example, you just mentioned, that requires hospice care as well. But the comment is correct. We do sometimes do the palliative care so close to the end where hospice is sort of linked up with palliative care so early. So palliative care early is great. I think when we wait too late, sometimes we miss the opportunity to provide more comfort and support for the end-of-life care. Yes.
You just mentioned end-stage dementia. Is that terminal?
So if your dementia is severe, yes. So there's mild and then there's severe where you can't even feed yourself and things of that nature.
Is that neurologically terminal dementia? Or, I don't understand.
I think perhaps the disconnect here is you're thinking dementia as in kind of cognitive decline. In and of itself is that a terminal condition, and it's usually linked to something that's progressive that will. So Alzheimer's would be a terminal condition, and dementia of the Alzheimer's type will eventually lead to death. Now, how much time that is very unique to the individual. Yeah, it depends on a lot of things. Yeah. So we talk about dementia as if it's a standalone thing, but it's actually dementia of a certain type. So like Lewy body dementia you've heard of, Alzheimer's dementia, dementia from stroke, cerebral vascular. Those kind of things are where the dementia comes from, but it's the entire condition that can be terminal. Now, if it's not a long-term progressive thing, that's what dementia, but if it's short-term, we call that delirium. And that's how we kind of differentiate between delirium. And delirium is a lot like when I was learning about it in graduate school, we'd say being drunk is delirium. So you know you're going to get over that in a couple of days. You may be impaired while you've been drinking, but shortly thereafter it'll come back. So you get delirium from drugs, delirium from alcohol, delirium from maybe some sort of cardiovascular event. Dementia would be more long-standing than that.
They get to the point, like with my mom, sometimes she gets to the point where she forgets how to eat. I mean, you've got the food in front of her, but she'll sit there and just kind of pick her fork up and push it around those plates. It's like she doesn't remember that she put that food in her mouth and eat. And sometimes, even if she gets it in her mouth, she'll forget to chew. So sometimes we actually have to feed her, and sometimes she can feed herself. Other times you have to feed her and remind her mom about to chew the food, about to swallow the food.
Right. Well, ours was, my mom was diagnosed April the 8th, and we're sitting here today, devastated that it has moved extremely fast. So,
She was like herself,
and then she wasn't.
and then within like 3 weeks, it was like off the chart.
And the neurologist, we did the MRI, and the neurologist explained that it was the right side of the brain. And we just had no idea it would go so fast, nor did I have an idea that it was coming.
Well, I don't want to make sure that we don't give a diagnosis, but certain dementias can be so debilitating that it can be what we call, there's no recovery from that and only gets worse. And they'll forget basic physiologic things like swallowing, and they're high risk of aspirating. And if you aspirate, you may stop breathing, and that could end your life. Or if they wander off and they get hit by a car, because they don't have the ability to think that that's not safe. So I don't want you to think that that's exactly what I'm saying that your mother has.
Well, we already have her safe, but just that it could lead to that, because as fast as it's moving, it's just really scary.
Yeah, it sounds like, and I'm sorry you're going through that.
Well, anybody's
Yeah.
It's horrible.
Yeah, but we were just talking with someone who had dementia for 20 years. And everyone is different. And so these are things that we basically can't put a timeline on. The aggressive nature of it is unsettling, and I just can't imagine what it's like for you to go through as a family. I know it's hard. We're not giving you a death sentence to that, but we are saying that hospice can get involved with that early and can give relief to the family, can give relief to your mother. It may be a good option at this point. That'd be something between you and your doctor.
They need to talk to that neurologist.
I think that would be an excellent next step, yeah.
Dr. Velarde.
I just wanted to make a comment about the understanding of these two concepts. It's so critically important for us as it is for families that we're confronted with situations like this where, and I believe that maybe one of the common So I find that very important, having you experts dealing with that. And I have had interaction with refugees with difficult families, and difficult because it's difficult for them, it's difficult for us. Not necessarily that it's bad because of that family, but it is something really important. I still want to understand the dynamics, because we as teens, we can get through because of time constraints or whatever, and then families feel that this is being imposed on them. They don't want to take care of my loved ones, they want to get rid of them. And we have to cross that bridge and try to understand one another. So,
And not, yes, and not all physicians feel comfortable. I do this every day, so sometimes I will see a patient for the first time and recommend palliative. Some physicians aren't as comfortable because it's not what they see all the time, so it is something that we need to get better at. I do often make it a point, if I'm consulting palliative or recommending palliative, I explain to the family what palliative is so that they're not shocked when other people come into the room and they're like, who is this person talking to me about palliative? I didn't know they were coming. So I do train my fellows the exact same way, that if we're going to call any consultant, whether it be orthopedics or palliative, we tell the family who's coming and why, so they're not surprised. And some patients need palliative when I see them for the very first time, so we're not waiting too late to provide that support for the patient and family.
One of the things our palliative team is really, really good at is helping families come up with goals of care. And one of the things that's hardest, I think, for our families is, let's say it's your significant other, and you are the next of kin. And so you're calling the shots. Well, you're not the only person that in your significant other's life. There are parents out there, and there may be siblings out there, and there are friends out there. And so you're not just calling the shots, but you're having to communicate with each of them what's going on. And invariably, somebody's not going to be happy with the job you're doing, or they'll disagree with what you think is best for your loved one. And you'll get caught in the crosshairs of that and say, well, did you ask the doctor this? Or I want a second opinion that. Or you're at Shands, you got to get away from Shands, you got to go to Baptist. And you get that. Those are real things that happen from people who are not directly involved in the system. And it's not fair. It's not fair for you. And it happens. And we try really, really hard to work with you and to work with your family and to get through that. But that doesn't really make it any easier on you, because at the end of the day, you've still got to be a part of that big system. And one of the things palliative does, and it gets at what you were saying just a second ago, is palliative can come in and help you bridge that gap, because that's their reason to be. All the other doctors are seeing lots of patients and trying to save life and function, and they do a very, very good job at that, but they may not have the time to be able to sit down and work through some of those goal plannings. And that's when we really seem to shine with palliative. And as Dr. Ross said, different doctors are more comfortable bringing in palliative. There's a question here a little bit ago, when you consult palliative, hospice doesn't automatically get involved too? And my response was no. But so often they do. And the reason they do is because what you just said, we wait a long time to get to palliative because we didn't quite get there yet. So I want to really be appreciative of what all of you all go through, as well as all of our other patients and their families. This is hard stuff. And we're trying really hard to work with you and help you. And sometimes we're going to get some pushback back, because that's normal. If it were easy, we wouldn't have talks like this. Difficult decisions at difficult times. That's what we're talking about here. None of this stuff is easy, and we try to be appreciative of that. For the most part, I think we get it pretty good. Sometimes we don't. Y'all let us know when we don't, and so we learn from that.
Who makes up the palliative?
We have palliative specialists. We used to have a guy named Dr. Borgman, who was our chief palliative doctor. He went on to work elsewhere now. Now, I don't know our team anymore.
Maharaj, Dr. Maharaj. And there's practitioners and case management. Correct.
But, so we just identified 4 people for the entire hospital. And so that's another reason why we don't overwhelm them with a lot of referrals, because it's a hard job.
And it's a new specialty
Yeah.
for residents in internal medicine. I believe it's a 2-year specialty. So after they do internal medicine,
Yeah, so Dr. Maharaj is our new palliative care physician, and he has a team of people that will come and see the patients and consult and do a great job despite the tight, small team fairly quickly and try to provide the support. Many family meetings, multiple family meetings for certain families, but that's okay. That's what we're there for. That's what they're there for. Yes.
Are discharge planning meetings still taking place? Is that still a thing on hospital units, unlike outpatient now?
So for us in trauma and acute care surgery, we do have an organized multiple days a week. Other services may structure it differently, so I can't speak for them. But we do have discharge, case management, rehab services meetings almost on a daily basis.
And that would be on every patient that
In trauma, every patient,
just for trauma?
well, we work for trauma. And
Yes.
so, but we talk about, I can't say every patient every day, it's we talk about ICU patients and floor patients intermittently, and then every patient on Monday. So,
We can only speak for our group.
If you're not in a hospital setting, is palliative care a situation you can access? Or is it only when you're in it?
well, first to answer that question, I want to go back to all doctors are palliative care doctors. All doctors are interested in comfort care and treating pain and discomfort and anxiety and all of that. So again, even though palliative is a specialty, just because someone's not a palliative doctor doesn't mean they're not palliating patients. So hopefully your primary care physician can have these conversations with you. If the question is, can you access a particular palliative specialist, I don't know.
I don't know that answer.
Does anybody?
What you said is really important because I think family medicine and general internal medicine teach this. This is part of training. Whether you go for the additional subspecialty training or not, the public might not understand that that is part of being trained as a physician for primary care.
Correct.
That is a legitimate thing for you to see from your provider.
Correct.
Yes.
Any other questions? Okay. So compassionate wean, allow natural death is the removal of some or all life support. It's usually in conjunction with the physician team or palliative care hospice. And that's when comfort care orders are given. And every facility may do it a different way. But we have what we call an order set that provides the nurses medications, additional support and orders to allow that to happen. So, for example, some patients' family says, keep the medications on board, but take the breathing tube out. Others are keep the breathing tube in, but stop the blood pressure medications that's keeping the blood pressure. Others are take everything away and just provide comfort medication. That includes medications for pain, and that includes medications for anxiety too. And it allows the nurses to give what they need to the patient when they see the patient needing more pain medication or anxiety medication as they're leaving us here.
This is likely the hardest decision a human being will have to make, is when it's time to say enough is enough. They fought the good fight. Things are not getting better. They would not want to live this way. And unfortunately, your doctors can't make this decision for you. They need you to decide as next of kin when this is. Sometimes the patient decides for themselves. They pass away, and but more often than not, it doesn't work that way. And it's hard. And your doctors will give you the best feedback they can. You may feel pushed at some point that the doctors feel that they're giving up. And that's generally not the case, but it's certainly a human response when you start talking about end-of-life kinds of things, that you feel like people are pushing you. Your families will push you. Other people in your life will push you to make a decision. We try our best to just give you the information and try to give you what our expectation is. What I can promise you is whatever decision you make is the right one, because you love them. And you're making your decision out of loving them. And so I'm never going to know your family the way you know your family. Dr. Rob won't, none of the doctors will. So we have to rely on you, and we will do our best to give you all the information and to give you frank discussions about what we expect. They're not going to wake up. They will likely never open their eyes again. But you will have to be that person, and we will do our best to support that.
Wonder if your family can't make that decision and they decide you need to stay on life support and you don't have a, you know, the will or whatever, and the doctors keep telling them you're not going to be any better, but yet they don't want to let go and it just keeps on and on and on forever.
That's common in our world, and that's why it's so important to do these forums, because this is what families do. Families have a hard time letting go. I'm not letting go of her anytime soon, and
I mean, you have to keep them with machines forever, or?
yeah. We will basically, we may not escalate care if we think it's not going to be effective, but we won't take away care that we just, no. And so, again, this is why it's so important to have these conversations, because this is the hardest stuff. And if not, even if not for you, even if it's, I don't want to be on those, by signing these forms, you're helping your family not to have make that decision for you.
Well, this is why I bring this up, because my sister, she was so hard-headed that I signed organ donation, and she fought me about me signing my own organs away. And she was bound and determined not to let that happen, regardless. But let's say that I don't have the forms filled out, and you have a hard-headed sister that just will not let you go. I mean, is there any other recourse?
The only way we can discharge a next of kin is to go through a court.
Okay.
Yeah.
And so we tend not to do that. And so, again, have the form signed. If that's a real thing and you know about it, it's just that much more important to get an advance directive signed.
We try not to be adversarial with families. We will work day and night to work with them. And so we've had families who are very resistant. And most of the times the patients will expire, even with their best of our abilities anyways, even though it was a lot longer than we anticipated. But we don't want to fight with families, and we do our best with our palliative care team, having multiple meetings, so we are on the same page. Majority of times it ends well, meaning there's no anger at the end. Even if it took us 2 weeks, 3 weeks, 4 weeks, we're there because we don't want to have fights with family. They're doing it because it hurts. They're doing this because they're upset, and we will work with that family member until everybody reaches a final point where they're accepting of what's going on. Sometimes they just need time to realize this person is not going to wake up. Their loved one is not going to talk to them or do the things that they were used to doing. Okay. She doesn't want to think about you going, right? She loves you.
I want to thank everybody for coming. I'm sorry, did I?
I think she had one more question.
Make one statement, 'cause
Yeah.
it did happen in our family. If you have a loved one who's signed a power of attorney to you, that is not in lieu of a will. The power of attorney stops when that person stops breathing. So don't think that, because you have the power of attorney, that, I can now handle their estate. You cannot. So it did happen in our family. Somebody thought that they were good to go and they were not.
Yeah, 'cause these terms are confusing, right? They're loaded with emotion.
Yes.
They sound alike, and they're confusing. So, but it is 7:30, and we do hold to this time, and I want to thank everybody for coming. If you would, before you leave, fill out your evaluation form, at least give me a couple comments, and if I don't already have you on my email list, and you'd like to get my emails about future programs, that's the only thing I use it for. Please put that on the form so I can add it to my reminder list. I want to thank everybody for wanting to come tonight. It's a difficult conversation. Our catering group gave us comfort food. I don't know if you noticed, but it was like chicken pot pie and strawberry shortcake tonight. And our speakers were excellent. Let's give them a round.
Thank you.